I'll start with Mike Chernew, who is one of the nation's most highly regarded economists. And really what distinguishes Mike is that not only is he brilliant on the theory and the research, but probably more than any other economist, he understands how markets work. And he leads much of the healthcare policy work coming out of Harvard Medical School, but he also sits on Harvard's Benefits Committee, where he learns firsthand why markets are not always efficient. Is that fair to say? So he also serves on CBO's panel of health advisors, is a member of the Massachusetts Health Connector Board of Directors, and was vice chair of MedPAC. We have the good fortune of having Mike serve on our NIHCM Foundation's advisory board. He is one of the pioneers of value-based insurance design and the go-to researcher for evaluating Medicare and private sector accountable care organizations. Please join me in welcoming Mike to the panel.
I am thrilled to be here. NIHCM always does an incredibly good job, and Nancy's always too nice in her introductions. It's tremendous to see all of you here, which is a testament to the caliber of my fellow panelists anyway. So I'm going to talk broadly about payment reform, a little bit of benefit design, but because Bob was going to talk about the budget, I want to start with some comments about the budget. So the quiz question to begin, I'm not sure Bob would have had this, but anyway, the quiz question is, what do these decades have in common? And the answer is, in every one, healthcare spending growth exceeded income growth. By varying amounts, in the 70s, we were 2% faster healthcare spending growth than income growth, and in the 90s, which was considered a very good year, a good decade for at least healthcare spending growth, healthcare spending growth only exceeded income by 1.6 percentage points. So that's a real fundamental challenge if healthcare is growing much more quickly than national income. So we've had, and I think one reason why it's great to be here today, an ongoing national discussion about what to do in the healthcare sector, and I'm going to largely talk about broad ideas, but I do want to make an important semantic distinction. In many debates, when people talk about the challenges we face regarding national healthcare spending, they're talking about total spending in the country, national health expenditures. There are other conversations when people are discussing the challenges associated with rising healthcare spending, but what they really mean is the government is spending too much. Those are different issues, and there's different solutions for how you're trying to address the total efficiency of the healthcare system and total healthcare spending in America relative to a concern about what the government's spending. So because I've spent time in a number of different settings, I'll make a quick comment about Medicare's challenge. So in 2015, roughly speaking, Medicare was a little bit, 3.5%, a little bit more percent of GDP, which, you could take that for what it's you will. If healthcare spending growth continued to exceed income growth by 2 percentage points, which is roughly the average, by 2035, we'd be up to 8% of GDP. If we're really successful and able to reduce healthcare spending growth to 1 percentage point faster than income, Medicare spending would be a little more than 6.5% of GDP. If we were stunningly successful, maybe I should emphasize stunningly successful, and healthcare spending growth rose at the rate of GDP, Medicare would still rise as a share of overall spending. And the reason is because we have more Medicare beneficiaries. So we have fundamentally two problems, the policy solutions for which are different. One of them is there has been rising spending per beneficiary historically in the healthcare system. And the second one is, in Medicare, we're struggling with how to finance a growing proportion of our population on Medicare. It should not be surprising that if we have more Medicare beneficiaries per worker, the workers will typically have to pay more to finance those beneficiaries. That's not rocket science math. But the implications of how you deal with a growing population are very different than the implications of how you deal with rising spending per capita. It's not just a Medicare problem. I think I'm not from DC, I think there's been some discussion about Medicaid. in the state houses and in DC, and as Medicaid spending grows, it crowds out a whole bunch of other things at the state level. So there's a huge challenge, not just about how we finance Medicare, but how we finance Medicaid. To give you some rough numbers, so basically, there's other parts of the budget we could think about cutting from. I don't want to go into broad fiscal policy discussions, but if you tried to fund healthcare spending growth through taxes alone, no borrowing, just taxes, and you raised everybody's income tax proportionally, and healthcare spending grew at 1 percentage point faster than income. Remember, the historical rate is 2% faster. If it grew at 1% faster than income, tax rates by 2060 would have to rise for the highest income group in the neighborhood of 70%, to 70%. So I'm waiting for the gasp. Hello? In any case, I don't think taxes are going to be 70% in 2060, and it is admittedly true that the power of compounding can make numbers seem enormous if you go out far enough, but the fact remains the fiscal challenges associated with rapid spending growth are real, and they create an enormous amount of tension in the system. As Nancy mentioned, I said I actually chair I have the honor of chairing, maybe the misfortune, but nevertheless, I'm going to go with honor of chairing the Benefits Committee, which advises Harvard University about what to do with our benefit package. And when we look at the numbers, we can see projections of spending growth that put huge pressure on the wages and the salaries of people that work at Harvard University. So although we often talk, and as I mentioned, about the sort of federal spending or the state spending problem, this is also a huge private sector issue about how we can control spending growth. So what I want to spend the rest of my time on is solutions, and just to be clear, I use that word loosely because I'm not going to have a great magic bullet at the end, so if that's what you came for, luckily we have other panelists. I'm going to talk about two broad areas of solutions. There are others. One is payment reform, and the other one is what I call consumer strategies or benefit design, things related to engaging consumers through the different ways, but largely through insurance packages. So it turns out that one strategy you might use to pay less is to pay less. It scores really well at the CBO, and you've seen an enormous amount of that in recent health reform discussions where the assumed increases in fees to physicians and hospitals and other healthcare facilities are lower than had been in the past. I'll give you a slide about that in a minute. No one that I know where I sit is thrilled about the just pay them less strategy, and there's a huge amount of energy around what are known as alternative payment models, way of paying differently. And the two big types of alternative payment models are episode payments or episode bundles, paying for an episode of care as opposed to every little service, and a population-based payment model, or in the federal context, that's largely ACOs. So to give you some idea, this is from Brookings and USC Schaefer. We had a system for paying physicians that was called the Sustainable Growth Rate system, which was many things that was not sustainable. And so we now have a rule called MACRA, which governs the way in which physicians are paid. And in it, there is a portion called MIPS, which is a pay-for-value component of it, which is fine, and I'm not going to talk a lot about MIPS. The thing that I think is most important to understand about the MACRA system is the scheduled fee increases for physicians are essentially flat in nominal terms, not inflation adjusted, in nominal terms for decades to come. There's some bonuses and stuff that go in there, but the key thing to understand is by roughly speaking 2042, physician fees, it's sort of the base level of physician fees, are scheduled to rise by a little bit less than 10% in nominal terms. The Fed is shooting for 2% inflation, so slowly over time there would be a reduction in the real value of the fees to physicians, and through the ACA, there's similar types of adjustments called the productivity adjustments for payments to facilities, where their fees are scheduled to go up less than their input prices. And that's, I believe, going to be a challenge for the provider system decades to come in the fee-for-service system. So what we have been trying to do is build a somewhat different type of payment model where physicians and the delivery system more broadly can capture some of the efficiencies. And by pooling those efficiencies out and allowing the provider systems to share in some of those savings, they can perform better financially than if they're just having their fees eroded by inflation over the next 20 or 30 years. At least that is the theory of how these types of models should work. In the advantage of these models, I was listening to a very well-known venture capitalist recently, who said these flexible payment models allow innovators to make changes in ways that aren't distorted by needing to create revenue by charging more for very specific services. So there's a lot of economic appeal to broader payment models. So I'm going to go through what those payment models are. They have three characteristics. The first one is they tend to transfer risk to providers. That can be a good or bad thing, right? If the providers create efficiency, that risk means they share some of that, those efficiencies. They include always a pay-for-performance component, a value component. That's why they're often called value-based payment models. And increasingly, I've grown to appreciate the data support. And many of the things that I think a lot of the insurers are doing is providing data support to enable providers to succeed under these new models, because it is always hard when you change a sector's business model. Often these new models go under the moniker of value-based payment. And you see this all over the place, you know, will the reconciling prevention and value from volume to value. The word value is a very commonly used word now in all these things. So that begs the question of what do we mean by value? My personal view, maybe a little contrary, this is Mary Poppins, is the word value is a little bit of the sugar that makes the medicine go down. What we're really trying to do is to shift some of the responsibility and accountability for providing high quality care to providers and then hold them accountable for the financial components shifting risk. And we call it value because it sounds much more appealing than sort of risk-based models. But a lot of what is going on here is not your standard pay-for-performance model. It is transferring risk and responsibility down to the delivery system. Episode-based payments have gotten a lot of attention. I don't have time to go through an exhaustive literature review, although I would love to do that actually in my longer talks. In general, I think the evidence is pretty clear that they save money. There are examples where they save large amounts of money, or at least they've been purported to save large amounts of money. On average, they save, 5-ish%, at least that's what we've seen. There's a lot of concerns, for example, that you save money per episode, but there could be an increase in volume of episodes. We're not sure if that's true. We haven't seen a huge impact on quality. You could take that as good that quality hasn't gone down. You could take that as bad because you hope the quality would go up, but there haven't been big consistent impacts on quality. There's several concerns with episode-based payment. One of them is that the episode models work well for certain types of conditions, hips, knees, maybe some other things. But the problems we have in this country, a lot of them deal with people with very complicated, interrelated chronic conditions that are much harder to put into episode models, and it's unclear how far you could go in capturing the total spend of the country or of any population in an episode-based framework. And then the second concern we have, of course, as I mentioned, was induced use. So let me jump to population-based payment models. We used to be called capitation, but we don't use that word anymore. And I think there's some differences with capitation, but nevertheless, the basic idea is that the delivery system gets a fixed fee to care for a population of patients over time. All of these, just to be clear, they're all built, at least almost all of them, are built on a fee-for-service chassis. That means during the year, the money is flowing in a fee-for-service way. But the delivery systems, or the organizations that accept this accountability, are responsible for the reconciliation at the end between what is spent in all those fee-for-service spending fees that are going out the door and the total budget. So, again, I would love to spend an hour and just talk about the evidence. It's been controversial. If you follow Twitter, this is like at least half the places where I am in Twitter is arguing this point. I believe the evidence is pretty clear that population-based payment models reduce spending by a small amount. So many people get disappointed, and by small amount, it differs across populations. The private sector clearly does better. And part of the reason why the private sector does better is because there's wide variation of prices in the private sector, and in these models, it turns out that the physicians, the organizations that accept this risk, they can shop better and they can save money by directing patients to lower price settings and providers. It seems clear that the results improve over time. And it also seems clear, at least in Medicare, that independent physician organizations do somewhat better. Now, that is a generalization because I'm an academic, so I'm paid to generalize. So I'm sure there are some tremendous integrated organizations, but as a general rule, it seems to be the case that if you want to save money by keeping you out of the hospital, it helps if you're not a hospital. So the other thing that is really important to understand, and I don't know why this is so hard to explain, it seems that I keep saying this and it doesn't sink in, is in a shared savings model, the savings get shared. Just so you understand how that works. So if you save $100 in less spending, that you're not going to keep that whole $100 because you shared it. That's how sharing works. And so if you look after a year, you're never going to do as well as you would have done had you not shared the savings. But understand, the shared savings are the incentive to induce the savings. If you didn't share, you wouldn't have any savings to then share. I think we have to worry about trying to create a healthcare system that is working in 2019. And so just to be clear, I really want the healthcare system to work in 2019, but I'm much more interested in us getting on a path where the healthcare system will work in 2025 and 2030. And if we spend all of our time trying to get a big win in 2019, we risk abandoning a path that might get us somewhere successful in 2025. So the reason why I have been supportive of these models is not because the evidence suggests huge savings, although I must admit, if it's savings money, and I might add improving quality, the evidence suggests, if you're saving a little bit of money and improving quality, in my book, that's a win. It might not be a slam dunk win, but that's a win. And the reason why I think we should keep moving on this path is because if we get all the regulations right, it enables the delivery system to control their destiny and to capture some of the efficiencies, which is, I think, ultimately where we're going to want to go. Some quick caveats. The details matter. We often say ACOs, they succeed, they fail, whatever they do. Remember, the details of these programs are very different. And the other thing that's really important to understand is execution matters. It's not simply you put in an ACO and it's going to, how it gets implemented, how it works, how the organizations that are doing this work accomplish their task ends up being really important. Don't underestimate the importance of management and execution. So my summary of this whole thing, we want a mansion, we have a dilapidated house, we know how to build a tiny house. So I don't know if anyone watches tiny houses, I don't know, now you know more about me than you need to, but the point remains, it's still a house, and hopefully over time, we'll be able to put on some additions. That's my sort of folksy answer to where we're going. Comparing episode and population-based payment, they may be able to work together, but some quick summaries. Both of them seem to lower spending. The problem with episodes is that they're narrower. So if you save 10% on 5% of care, you haven't saved that much money on a population basis. The other models are broader, but the concern is that not all geographic areas in the country are yet ready to support population-based payment. So for a while, we're going to have some mix of these types of models moving on, and it is also the case that specialist episode models engage specialists better. The other ones tend to be focused on the organization that employs the primary care provider. You can take that as better or worse, it's just a distinction. Should they continue? Again, I believe they should, in part because MACRA's current law, and I think MACRA is going to be really, really challenging given the fee level trajectories. The same is true for the productivity adjustments, and it's going to be hard to put in more money. So my general view is when money gets tight, and I hope my beginning slides convinced you money will be tight, the providers are going to want to control the money. And the overarching theme behind a lot of these new payment models are mechanisms to allow the providers to control the money, to capture and share in some of the savings that they create. So now I'm going to switch gears to benefit design. Understand that one thing about insurance is the goal is to mitigate risk. Again, it shouldn't be surprising that the purpose of insurance is to insure, but sometimes we forget that part of insurance. So we're balancing risk spreading and incentives in a variety of ways. The goal of cost sharing is not simply to lower premiums. It is relatively easy to have premiums go down if you make the patient pay more at the point of service. That is not a clear win. That is just shifting from a premium to the point of service, which adds risk, that does not diminish risk. The other issue about cost sharing is the goal is not to tax the sick. If you have very high cost sharing plans, who's pay? The sick people pay. At Harvard, I will just speak for Harvard, our goal is not to balance that or meet the healthcare challenges that we face by charging all of our employees that have cancer or heart disease or all the other many things, even some wonderful things like have babies. We're very pro-baby. Our goal is not to charge young families to support our healthcare spending. The reason why we have cost sharing is we're trying to improve the incentives in two particular ways. One of them is we want to reduce excess utilization, and I don't have time to say, but you probably know there is waste in the system. We would like to have less of it. And we would like to encourage price shopping, particularly in the private sector where there's huge variation in prices. You would like to be able to use benefit design to encourage some of that price shopping. So a few options, there's high deductible plans, high copays, high cost coinsurance plans, essentially models that charge patients more. Those tend to be very blunt instruments for a variety of reasons. Very sick people, for example, get above the out-of-pocket max and they face no incentives for cost sharing. There's a lot of evidence of HDHPs that they don't encourage shopping, even though we would love them to encourage shopping. Most of the newer, more advanced benefit designs try to target a purpose, either price shopping or reducing overutilization and encouraging use of high-value services. So reference pricing is the basic idea that you pick a price, and if an employee goes to a higher price provider, they pay the difference out of pocket. That steers them to the lower price providers and in fact encourages the higher price providers to lower their prices. Tiered networks is a very similar concept, but it's not for a simple episode type of care like a hip or a knee, but it's for all of your admissions or all of your care. So both reference pricing and tiered networks are about largely steering patients to lower price places, the higher value places often. The value-based insurance design concept is the idea of trying to align copays with value. So my colleague Mark Fendrick would be frustrated with me if I didn't mention that if you look at the care that we get, some of that care is incredibly high value, and we want people to consume that care. Other care is lower value, and we would rather discourage people from using that care, and there's this nuance. The idea behind value-based insurance design is to align the cost sharing with the value to encourage the high value, discourage the low value care. So the basic results from all of these benefit design studies is it is thankfully to an economist good news that people respond to cost sharing. Financial incentives matter. Maybe I should say that again professionally. Financial incentives matter. They shift the site of care. Patients in reference pricing or tiered network plans move to lower price services. Not all of them, a relatively small percentage of them, but there is movement associated with that. To give you some idea, there's potentially large savings in a reference pricing model, but on a narrow amount of care, hips or knees. In a tiered model, one study we did suggested about a 5% savings on a population basis. It is also clear that higher cost sharing reduces use. High deductible health plans have, depending on your study, 5 to 14% savings in terms of use. Value-based insurance design, which is more nuanced, the results depend on exactly what you've done. How much emphasis have you put on encouraging use of high-value services? How much emphasis have you put on discouraging use of low-value services? So how you design it's going to depend on, going to determine the financial implications of a VBID plan. Some basic concerns, and this is the one that's really important, and I have to say a little bit disturbing to an economist. I was gloating before, but now I'm a little sheepish. Cost sharing does influence patients' behavior. Just patients don't respond the way that clinicians might want them to respond. They reduce their use of high-value care and low-value care in about the same proportion. So they reduce the use of preventive services if you charge them for preventive services. They reduce their use of high-value pharmaceuticals. There's a number of really high-value pharmaceuticals for treating diabetes, heart disease, a whole slew of things. If you charge people more for those things, they actually use less of those high-value things. They're not that good at discriminating. That's actually one of the motivations for value-based insurance design. You can use the cost sharing to, I don't want to use the word manipulate. It makes me sound evil, and since you already think that since I'm an economist, I'm worried. But it allows you to set up a benefit design to align what you want patients to do with what would be clinically valuable. There's another concern with all these benefit design things that you're transferring risk. So remember, the purpose of insurance is to mitigate risk. If you charge people a lot, you're undoing that. And of course, one thing we've been very worried about is disparities. If you charge people more out of pocket, you really, really have to worry that's going to impact some populations more than other populations. And so a consumer-oriented strategy always has to grapple with the disparities concern, particularly given that people aren't always the best decision makers in terms of what care they should get. So a few final thoughts. The first one is keep it simple. It is really easy to come up with dramatically complex, nuanced solutions where people are going to have to choose amongst different providers and different services and benefit design, or their providers are going to have very complicated regulations about how they're going to do things. the quality measurement system we have in this country, and I should say I'm a big fan of quality measurement, but it has become a big, complex entity that creates costs throughout the system. You'll see this if you spend any time talking to anybody that's had anything to do with MIPS. There's a lot of concern about that, and I think as a guiding principle, we should do our best to try and keep the system simple to avoid this sort of crushing administrative distraction that we could create if we weren't careful. And the last point is, and maybe the most important one is, don't be so impatient. If you came here today, and if you go to whatever talks you're going to next week and the week after that, if you're going hoping that there's going to be some magic solution, and if we just get rid of whatever we're doing now and put in this other spectacular thing, that's not the way the system is going to work. By and large, my view is that the roads to success is always under construction, and we should be happy with small wins and incremental improvements driving in a direction that we think will promote value using both incentives to the delivery system, payment reform, and incentives to the patient's benefit design, and hopefully we'll be able to get to a place that's fiscally sustainable. One way or another, we are going to control healthcare spending growth because in the end, math is going to win. But we have to figure out how to do that in a way that maintains the quality of care for folks because frankly, that we have a healthcare system designed to meet people's healthcare needs. And I think we're on a reasonable path, and hopefully with continued work, we'll keep moving in the right direction. So thank you very much.